Morning, good morning, good morning. Okay, that works. All right. Okay, can you guys all hear me on Zoom?
Yeah.
Yeah, we can.
Excellent, okay. Anna, how'd your procedure go?
It was good. They definitely found more than they wanted to find.
Or that you wanted them to find?
I think it was the meniscus was also torn as well. So then they had to partially sew that back up, and then they also found arthritis under my knee, so they had to scrape that as well.
It spurs.
Yeah. So not for sure like if that necessarily means that it will take me longer to get back or not, but they said that it would probably cause a little bit more pain. So
Well, that's good because the spurs can
Yeah.
cause more damage. So,
yeah, so that is good that they found that.
okay, so that's actually good that that was dealt with then.
Yes.
Cool. Okay. Erin, you still feeling lousy?
Yeah.
Okay, I hope you're better.
Thank you.
Okay. Stephanie, how you doing? You feeling all right?
Yeah.
More
As
or
much as I
less.
can.
As much as you can. Okay, that's kind of par for the course these days. All right, let's take a look at our. I'm not even going to try to run this because that just always fails. All right, we were here last time. Okay. Well, hello to our skeleton crew out there. 6, 7, 8. There's 8 people in class today, gang. So if you're not around, don't feel badly. Neither is anyone else, it seems. Let's get started. It's raining, which is just perfect, which means soccer games and baseball games and softball games have all been canceled and rescheduled. Let's pray. Father, thank you for the rain because it will make food grow. We pray for our country and the really lousy inflation numbers we heard before. We also pray for our students who are healing. Please heal them. And now, Lord, help us to listen and learn. In Jesus' name, amen. We were talking about inherited aortic disorders, and we saw that the aorta is made of elastin. Mutations that affect the structure of elastin, like Marfan syndrome, like the Loeys-Dietz syndrome, they will weaken the side of the aorta. It'll cause the aorta to prematurely bulge. And if it bulges, it can pop. And if it pops, you're going to bleed to death internally. Not good. So Marfan syndrome is due to mutations in fibrillin, which is a subunit of elastin. Elastin also binds this transforming growth factor beta protein. Without the sequestration of transforming growth factor beta, this growth factor runs amok. And that's one reason why Marfan syndrome people tend to be so tall. Now, Loeys-Dietz syndrome is a mutation in one of the TGF-beta receptors. And that can also cause weakenings of the size of the large vessels. So this particular syndrome as well, as you can see here, is associated with aneurysms, arterial dissections, and things called tortuosities. This means an abnormality of the development of vessels. Instead of vessels kind of going straight to the source, they kind of take the scenic route, as it might be, and you get vessels that do this. Anytime you get vessels that have abnormalities where you get knots of vessels or things like that, those vessels are subject to higher turbulence, so they're subject to higher rates of atherosclerosis. They also have higher shear force on them, and those higher shear forces will cause them to have more atherosclerosis, but also be more likely to undergo rupture and infarction and so on and so forth, especially if the sides of the vessel are weak. Now, with Loos-Dietz syndrome, you also tend to have skeletal abnormalities. Transforming growth factor beta is very important for elongation of bones and the growth of the long bones. So skeletal abnormalities, particularly in the long bones, are common. And that is, both of these syndromes are inherited as autosomal dominance. You just need one copy to manifest the syndrome. Now, as we said before, these genes here, all of them are subject to genetic testing. They're very good genetic tests for all of them. They're tested in a group of genes. That website I showed you, the test actually is for 29 different genes that are all tested at once. And these types of tests are pretty high quality. And the amount of sequence data we have is such that we have a pretty good idea if you have a variant of whether or not it's going to be pathologic or not. Now, it doesn't mean every variant is well categorized, but most of them are. So genetic testing in this case can usually be trusted. You may get an indeterminate result, but that won't be the usual result. With these genes, usually the result is pretty clear cut. So to summarize, the inherited forms of thoracic aortic aneurysm and dissection, they are caused by mutations that affect proteins that make connective tissue, in particular the connective tissue that helps reinforce the walls of these large vessels. Because of that, you get a loss of integrity of the vessel. You may get pulling away of the inner layer of the vessel. That's a dissection, or weakening of the side of the vessel, and that will just cause a bulging. You get aneurysms at an earlier age than in the sporadic case. So the severity is based on the type of mutation, the severity of it. These will show variable expressivity, remember? The dilation is visible on imaging, but folks, normally when you go in for a physical when you're an adolescent, you don't tend to have imaging. But if this runs in your family, then you need to have proper imaging of the aorta and read that routinely. And that's the case with Marfan syndrome or any of the other associated syndromes as well. And bundled dissections should be included in any history as of the patients as should chest pain. And if you end up with a aortic aneurysm, that aneurysm may end up pressing on ganglia or even the spinal cord. So you might get various types of pain. And if you do get a dissection, you get really ridiculous chest pain and then pulse deficits. The pulselessness, that's one of the first signs that you've got a dissection. And so if you have first degree relatives with this, you have to have annual imaging of the aorta starting in childhood. And then pregnancy will present a special consideration. You should, women with this condition should go to an OB who specializes in high-risk pregnancies, because you are a high-risk pregnancy. Your patient is a high-risk pregnancy. They are a high-risk pregnancy in that case. If you put in this website, this tells the story essentially of Tyler Kale. And Tyler Kale, as you can see here, had a aortic dissection at a very early age. And there's 3 videos. They're too long, unfortunately, to show in class, but you can watch them. And if any of you are interested in cardiac nursing, cardiothoracic nursing, this type of story shows you essentially the type of patient that you might be dealing with and the types of risks that they suffer with. Very good. So are there, oh, didn't mean to do that, but are there any questions about the familial thoracic aortic aneurysms and dissections before we move on to familial hypercholesterolemia? No? Then let's go to familial hypercholesterolemia. So this is a topic we've already talked about to some extent in other courses. Come on, you. Oh, there. Come on. Yes. Okay. Now you'll let me go forward. All right. There. So familial, as you hopefully figured out by now, simply means that the disease runs in families. It has a genetic etiology. So that the condition has a genetic predisposition. Hyper, of course, means excess. And then cholesterolemia refers to the blood levels of cholesterol. So familial hypercholesterolemia, very simply, is a genetic disorder associated with high levels of blood cholesterol. So cholesterol, very simply, as we said before, it is a lipid molecule. So it's a type of fat, I suppose. It helps maintain the rigidity and fluidity of membranes. It's a precursor to the synthesis of steroid hormones, also a precursor to the synthesis of bile salts and bile acids, and also vitamin D. Cholesterol is carried throughout the body in several forms. Chylomicrons that come from the gastrointestinal tract sends it to the liver. That handles dietary cholesterol. VLDL is reduced from the liver, and then that sojourns through the blood, undergoes transition to IDL and then LDL. LDL is the so-called bad cholesterol, and then HDL, which is the so-called good cholesterol, which is used to take excess cholesterol from cells and return it to the liver. So what makes the LDL bad and what makes the HDL good? If there are high blood concentrations of LDL, then it can find its way beneath the intimal layers of blood vessels. It'll get oxidized and then it'll be ingested by macrophages. And these macrophages will die if they get too much of that oxidized LDL. They'll become foam cells, and then they will form atherosclerotic plaques. That's the Reader's Digest version. I've explained that in more detail in other classes, but you get the point. So these So the blood vessel essentially wall, as it gets cholesterol deposited beneath it, this will then be ingested by macrophages, and macrophages will become foam cells. And initially, it's called a fatty streak. The fatty streak is still flat, but as this will start to cause smooth muscle cells to proliferate and surround it. Now, eventually, this will start to and you'll start to get the deposition of fibrin and stuff like that, and then smooth muscle cells and things like that. And you now have this structure that starts to occlude the vessel, and if this gets even bigger, it can occlude it even more. And if this erodes and you erode that, that is highly thrombogenic, and you form a thrombus, and then that thrombus can fill up the whole vessel and essentially cause an infarction. So in individuals, LDL is removed from the blood by binding to an LDL receptor. So if this is an LDL receptor, and say you have an LDL particle, The LDL receptor, after it's bound to the LDL, is brought into the cell by means of something called a coated pit. This is called a coated pit. You bring it into the cell, and then that coated pit pinches off into a vesicle. This process is called receptor-mediated endocytosis. Or sometimes abbreviated RME, receptor-mediated endocytosis. From here, this is an endosome. The endosome will fuse with a lysosome, which is yet another vesicle. These two will fuse, and the lowering of the pH will dissociate the LDL particle from the receptor. The receptor then gets recycled. So these two will fuse. The receptors then get recycled back to the membrane. The LDL is broken down, and the cholesterol goes into the cell, and it shuts down endogenous cholesterol synthesis. Now, why mess with all this rigmarole when we talk about familial hypercholesterolemia? Because depending upon which mutation you have, you affect different steps of this process. So there are over 900 different types of mutations that have been shown to cause familial hypercholesterolemia, and they've been grouped into 5 different classes. So class 1 mutations, they affect the quantity of LDL receptors on the surface. They affect the quantity of LDL receptors on the surface. You have fewer receptors on the surface, so you can take up less cholesterol. Therefore, your serum LDL levels are much, much higher. Class 2 mutations. Class 2 mutations. These affect the intracellular transport of LDL receptors back to the cell surface. So the LDL receptor goes here, then it gets degraded in the lysosome. The signal to recycle it, the cell never quite gets the memo. So here you have poor LDL receptor recycling. That also drops the quantity of LDL receptors. So you have more LDL in the blood to cause atherosclerosis. What about class 3? Class 3 mutations affect the binding of LDL to the LDL receptor. Now, what does that tell you about where the mutations are in class 3? Sorry? Yeah, but not just the receptor, the part of the receptor that's outside the cell. Mutations in this class in the receptor are in the C-terminus, because the signal to recycle it is in the C-terminus. There's a sequence that's has a couple of lysines and then 2 other amino acids that don't matter. That particular set of amino acids tells the cell, oh, this is not supposed to go to the lysosome, this is supposed to get recycled. So it's actually here, so that signal is right here. This mutation is here, or it's a mutation in the part of the LDL particle that binds to the LDL receptor. And in fact, mutations in the so-called ApoB100 that's the target for the LDL receptor. That will cause a class 3 phenotype as well. So you have mutations in the outside extracellular domain of the receptor or in ApoB100 that binds a receptor. So now the cells won't recognize LDL at all. So basically LDL gets to run free throughout your body and cause as much havoc as it wants. Class 4 mutations. LDL receptor binds the LDL particles, but it gets stuck right here. Can't quite make the whole coated pit thing. That sort of thing just doesn't happen. So there's a machinery in the cell that causes coated pit to vesicle happen. And the LDL receptor is too screwed up for the machinery to recognize it. That's a class 4 mutation. So once again, cells can bind LDL, but they can't take it up. Drag. Lastly, class 5 mutations affects the recycling of LDL receptors, except whereas class 2, it's just this step here that's interfered with. With class 5, it's somewhere in this whole process that's messed up. It's before this last step where things get messed up. So class 5, LDL receptor recycling. Let's say earlier stages are affected. Now, with the, let me stop, make sure you're done getting this all down. Get ahead of everyone. Guys are all so sedate today. Your hands are on your heads are on your hands. You all look so tired. I'm tired too, so hang in there. With familial hypercholesterolemia, you see a genetic phenomenon known as incomplete dominance. Incomplete dominance. You guys have seen this before. How many of you guys in your garden have snapdragons? Nobody? Nobody got snapdragons? 4 o'clock, they're called 4 o'clock sometimes. They're about this big. You just bought a house, you're landscaping now. Come on. You know what snapdragons are, right? It's starting, but you know what snapdragons are. No? In honor of this class, you weren't supposed to plant something. They're biennials, you have to plant them every 2 years. Yeah, the bulbs come up every year. So snapdragons, if you get red and white snapdragons that come up, the next year you get some pink ones that come up. Because the red is homozygous dominant. The white is homozygous recessive. The pink is a heterozygote. So you get a phenotype that's intermediate between the dominant homozygous and the recessive homozygous. That's incomplete dominance. So that means you get a graded set of phenotypes. That's what you see with familial hypercholesterolemia. So it is inherited as an autosomal dominant typically, but people with one copy of the gene will show phenotypes, but the phenotypes aren't nearly as severe. They won't show symptoms nearly as early as people who are homozygous. That make sense? So you have one screwed up gene, yeah, your cholesterol is high, but it's not scary high. You get two copies of the messed up gene, now your cholesterol is scary high. And everybody with mutations in these genes will have cholesterol that is higher than normal. Pause right there and make sure that everybody gets that. Now, there is a higher frequency of familial hypercholesterolemia that occurs among certain populations, those being South Africans, French Canadians, Lebanese, and people with Finnish extraction. South Africans, French Canadians, Lebanese, and those of Finnish extraction. So hypercholesterolemia, we talked about this in farm, but not all of you are in farm. So remember that your ideal serum cholesterol is 200, below 200 milligrams per deciliter. If you're above 240, you have hypercholesterolemia. These individuals are going to have cholesterol blood levels, total cholesterol blood levels that are 4, 5, 6, 7, 800. No, really high. Really high. So they can have cholesterol levels that are scary high. So what kind of symptoms do you see in people with familial hypercholesterolemia? These symptoms relate to how cholesterol is deposited in the body. Excuse me, excess cholesterol is deposited in the body. One of the places that has a high affinity for excess cholesterol is tendons. So you'll get yellowish collections of cholesterol that will appear in various places around the body, but they will tend predominantly to occur in tendons. These are called xanthomas. Xanthomas because they are yellow. Xanthomas, xanthomas. So tendon xanthomas will occur on the hands, elbows, and knees, but the place where you see them most commonly is on the Achilles tendon. So in a physical examination, one of the first places you should look in a person with familial hypercholesterolemia is their Achilles tendon. Achilles tendon. You should have them take their shoes and socks off and have a look at the back of their foot, because that's usually where you'll see it. And then, of course, look at the hands. You'll also see them, again, elbows and knees. So look at elbows and knees. You'll also see them commonly around the eyelids. Around the eyelids. And I believe I have some pictures of these. Yeah, here we go. Here's some xanthomas. So this is called xantholasma. I'm going to spell this right, so I might as well just look. Papabrarium. Yeah, I got that right. Papabrarium. And this is the xanthomas around the eye, on the eyelids and things like that. So eyelid xanthomas. And you can see these. You'll also see cholesterol deposits on the outer border of the pupil. That's called arcus corneus. Arcus corneus. This is gray. You'll see that very easily with a slit lamp. And lots of doctors' offices and hospitals will have slit lamps. So in fundamentals, you'll be taught how to do a slit lamp examination. So the slit lamp, the big thing about a slit lamp is it's common for people when they start to just take your time. Take your time. Put across the eyes slowly and watch. And for goodness sakes, when you're being examined, don't say, oh, I see it, when in fact you don't. Make sure you take your time, and if the preceptor says, do you see it? If you don't see it, just say no. Please, I want to see this. I want to do this right. And there the xanthomas essentially on the hands. You can see the tendency for them to appear on the tendons. You got to admit, that's going to be hard to miss. Right? Yes. I'm getting blank stares from you to say, oh, I don't know, I might miss that. Those are particularly bad ones, but when you see them, they're pretty hard to miss. So the excess cholesterol, of course, can also deposit in arterial walls. They will narrow the arterial lumen. That will cause tissue ischemia. The tissue that gets ischemia depends upon the artery that happens to be affected. If they affect the coronary arteries, then you'll block blood flow to the heart. That will cause ischemia of the heart, and you'll have angina pectoris. If the blood flow gets cut off entirely, you may have a heart attack. If you get cerebral arteries that are blocked, you can have signs of an ischemic stroke. Weakness on one side of the body, slurring of the speech, dropping of one side of the face, and loss of balance. So how do you diagnose familial hypercholesterolemia? You order a lipid panel blood test. Order a lipid panel blood test. That will show the levels of total cholesterol and LDL, both of which will be very, very elevated in these patients. To confirm it, you'll need to do a genetic test. And again, these will be panels of different genes because there's several different genes involved. The big one is the LDL receptor. And fortunately, the LDL receptor is genetically very well known. The alleles it causes are very well understood. And these tests usually are very good at picking this up. So as it says here on the slide, the LDL levels will usually be twice the upper limits of normal. When you see twice the upper limits of normal, that's the difference from high to scary high. Twice the upper limits of normal, that's scary high. So the atherosclerotic disease will develop in the 3rd or 4th decades of life. The homozygous form may even be detectable at birth. All right, we talked about these bits here before. The pathophys, I went over. We talked about that. Okay, we talked about this. So mutations in the ApoB100 gene, they can cause a type of familial hypercholesterolemia. This is one of the genes that will be sequenced in the panel that for which you test. A single amino acid change in this case can actually prevent the ability of the LDL receptor to bind it, so you can have a normal LDL receptor and yet still have familial hypercholesterolemia because of this loss of function mutation in the ApoB gene. This will prevent LDL particles from being properly removed from the bloodstream. This particular related disorder, this gene is called LD-LARP1. This is an autosomal recessive. Inherited as an autosomal recessive, the receptors have perfectly normal ability to bind LDL, but they get stuck right here. So this is one of these ones where you have an inability to internalize this to be a class 4 type of familial hypercholesterolemia. And then the PCSK9 protein. PCSK9 binds to LDL receptors and it marks them for degradation. It's normally used in the cell to get rid of defective receptors. But there are gain of function mutations in PCSK9 that can cause this protein to glom on to normal LDL receptors, thereby causing LDL receptors to be degraded every time they get internalized. So this is an example of a class 5 type of mutation. There are medications now that inhibit PCSK9. There are monoclonal antibodies that bind it. They are given subcutaneously. We talked about some of those in our pharm class. So those antibodies work for the mutant proteins as well. So they can be used to treat this type of familial hypercholesterolemia. Lifestyle modifications are essential for people with familial hypercholesterolemia. They need to quit smoking. They need to quit alcohol. They need to lower the amount of saturated fats in their diet. And so they need to stop eating fast food and stop eating certain types of dairy that are known to be high in fat. There are certain conditions, certain medical conditions that are known to increase hypercholesterolemia. Those include hypothyroidism and nephrotic syndrome, certain types of liver disease, Cushing disease, so on and so forth. So can certain drugs. Steroids are the big ones. Oral contraceptives as well, particularly ones that contain estrogen. So combination, birth control pills, diuretics, and then particular types of alpha blockers. So it's very important that you rule out secondary causes. Now, these secondary causes will tend to not cause the LDL to get into that scary range. So you're going to want to test people who have this in your family, and you'll want to do a proper fasting lipid profile. And then you want to know essentially if they have had someone in the family who had coronary artery disease early in life. If they have first or second degree relatives who have this, because remember, they only need one copy of these genes in some cases to have elevated cholesterol, you want to make sure that you genetically test that. So if you have a family history of coronary artery disease, you have one parent with a total cholesterol that's greater than 240 mg per deciliter, and that can often run in families. And then other risk factors, high blood pressure, smoking, sedentary lifestyle, obesity, excessive alcohol intake, not occasional. They have a glass of wine every now and then. That's not something to be concerned about, but excessive alcohol use. People, I don't think, realize how calorically dense alcohol is. Alcohol is actually rather calorically dense. And so if you have a good deal of alcohol with a meal, that's actually quite a few calories. Also, your body will tend to metabolize the ethanol first before it will metabolize anything else. Or if they have the presence of other diseases known to be associated with high fat levels, diabetes, things like that. So what is acceptable? Again, the acceptable is below 200. Ideally, LDL cholesterol, ideally, you'd like to see that below 100, but you're willing to see it below 130. High, of course, is 240. If your LDL cholesterol is below 160, that's too high. And then for adolescents, usually your range is here. Adolescents, because they're growing, will tend to have lower levels of serum LDL. So the lipid profiles that are done, the plasma is isolated from the blood, and then the total cholesterol is essentially isolated, and then you use a phospholipidate complex to precipitate the HDL. You measure the cholesterol in that, that's your HDL cholesterol. The remaining cholesterol is, well, that plus what remains, that's your total. And then from that, essentially, the LDL cholesterol is the one that will usually, you can separate it using buoyancy. It's actually very easy to do. And then that cholesterol is your LDL cholesterol. So you get total cholesterol, LDL cholesterol, HDL cholesterol, and triglycerides. And that's your lipid panel. You're supposed to have these before you initiate any sort of lipid lowering therapy. And you then essentially, after 6 months, you essentially look and see if this is working. That's what you do. Remember, medication that's used for this, statins, you always want to make sure that you start them very low dose and then work your way up, because some people don't tolerate statins. You tell them to start at 5 mgs. So they take a 10 mg pill, cut it in half, and then take it. For people with familial hypercholesterolemia, you'll have to use your high activity statins, atorvastatin or rosuvastatin. The other statins aren't powerful enough for these. This is just a Fredrickson classification that we're talking about. Yeah, blah, 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 so on, blah, 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 the punchline. That's more for lab rats and things like that. So things that modify low density cholesterol: cigarette smoking will raise it. Hypertension makes the tendency to have atherosclerosis higher, so you want to make sure the blood pressure is controlled. There's a family history of coronary artery disease, or people who have structural issues with the coronary artery system in their heart. If there is a twist or a bend or something like that, that area is subject to higher turbulence and will tend to have a higher risk of experiencing atherosclerotic plaques. And then men, of course, 55 years of age, women, just men will tend to feel because of testosterone, men will tend to have atherosclerosis more than women. Also, women are protected by estrogen during that time when they are premenopausal. So your goal is an LDL, serum LDL less than 100 mg per deciliter, and statins are your drugs of choice. You can combine statins with a drug for dietary cholesterol called ezetimibe. Ezetimibe is just for dietary. This prevents the absorption of dietary cholesterol, doesn't drop the LDL enough in someone with familial hypercholesterolemia. But that drug plays well with statins. Also, lifestyle changes are going to be absolutely essential. They're going to need to increase their consumption of fruits and vegetables. And also, if they have diabetes and hypertension, manage those properly. And because inflammation plays such an important role within blood vessels, you also want to decrease inflammation. Dietitians are underused in medicine today. Recommending that someone visit a dietitian, it's not an insult. If they say, well, you know, I don't know where to start, or more commonly, they may say something like, well, you know, I tried this and I tried that, and nothing really seemed to work. send them to a dietitian. A dietitian usually will have lots of good advice and also be able to recommend cookbooks that allow them to prepare the types of foods that will be better for them. So if they don't know where to start, recommend they go see a dietitian. Say, ask the provider to refer you to a dietitian. That way your insurance will pay for it if you have Blue Cross Blue Shield, the bottom feeders of the health insurance group. Yes, you may quote me on that. And that will help them essentially get started, essentially. You also want to try to introduce fewer saturated fats, more of the monounsaturated fats, like the kind you see in olive oil or other types of vegetable oils and things like that. And as it says here, non-compliance is the biggest barrier to lifestyle changes, but lifestyle changes really can make a significant change. So eating more fish rather than red meat and fruits and vegetables and things like that. And if I can say this too, and I know I'm probably in some extent preaching to the choir here, but a lot of you guys are athletes, a lot of you guys work out, you guys are very fit. I think it's gonna be hard for a patient to take advice from you about lifestyle changes if you're not living that way. You know what I mean? So I know when you start working and you have families and stuff like that, trying to find time to work out is ridiculously hard. But trying to essentially follow a healthy lifestyle, you're talking to people about their health. You're trying to get people to have good mental health practices and good dietary practices and things like that. If you're not practicing that, it's going to be hard to convince somebody that they need to do that. So just something to consider. I don't want to be too preachy about this, but it's been said to me several times. I had a friend actually, unfortunately he's passed away now. Oh yeah, the dietitian I went to, she probably weighed 300 pounds and she told me I needed to change my diet. Why should I listen to her? And I'm just thinking, okay, number one, that's the wrong way to view this, but he's kind of sort of got a point. Yeah. Why are some of you looking at me so guilty? Goodness, some of you guys, seen some of you guys in the gym, you guys put me to shame, so stop. Just something to keep in mind as you go into your careers and you get married, you have kids, and life kind of catches up with you sometimes, and you don't get the time to work out that you wish you had, especially when you're pulling 12-hour shifts. And, oh, we're going away on the weekend. Can you handle my shift too? And, oh, okay. So you end up pulling double shifts and stuff like that. Oh, I'm so tired. I'm not going to go to the gym today, and so on and so forth. And it's just hard for you, I think, to give believable advice if you're not following that advice for yourself. Maybe you should say, I really don't want to do that double shift because if I don't work out, I get grumpy. And I don't want to be a grumpy nurse. Statins are the go-to drug. Statins, if they are taken properly, they do a really good job of reducing LDL and they raise HDL to some extent. Statins, fortunately, are effective at several different doses. Usually people with familial hypercholesterolemia will have to be on high doses. On the average, statins are well tolerated. Some people do get upset stomachs, but that tends to go away. Muscle pain is usually the biggest issue. Taking coenzyme Q10 can usually deal with a lot of those muscle pains. They will need to have kind of yearly liver enzyme checks just to make sure. Some people will get liver damage. That's not common, but it happens. And then the muscle pain is the other thing, and rhabdomyolysis is a potential issue. You see that in about 1% of cases. And the signs of that is really intense weakness. And then you're starting to see really dark urine. You'll see myoglobin and things like that in the urine. And they might even have flank pain from kidney damage. That's rhabdomyolysis, and you want to stop the drug right away. Ezetimibe, I talked about that already. That drug is quite well tolerated. That can be used with statins. And then bile acid resins are used for people who can't tolerate statins. These don't work nearly as well as statins, but they bind up your bile and they prevent you from recycling it, so they drop LDL levels. These drugs are not systemically absorbed, so they don't cause systemic side effects, but they tend to cause bloating and gas and what have you. You have to take them with a lot of water. Out of the bile resins, cholecystectin is the one that's best tolerated. They also increase the risk of gallstones. Niacin will raise HDL, lowers LDL maybe a little. If you take niacin, take prescription niacin, don't take over-the-counter niacin. That's been associated with liver damage. You have to take a lot of it. You have to take 1 gram. So upset stomach is an issue with it usually. Should be taken with food. Don't take niacin with alcohol. Say goodbye to your liver. Don't take it with alcohol. The biggest thing with niacin is flushing. There's no flush niacin you can get where niacin is gradually released. That's prescription, niaspam it's called. Or you can take a aspirin 30 minutes before the niacin and that will prevent the flushing. It's also best if you take niacin with food. And the fibric acid derivatives, these lower triglycerides. These are not indicated if your LDL is high, but your triglycerides aren't. So these are used for triglycerides. As you can see here, as the LDL levels go up, your risk factors start to climb. That is also the case if you keep smoking and drinking and don't change your diet and what have you. If you can get someone to take their medication, you can get their LDL down into a reasonable level, they can really mitigate their risks of heart disease and what have you. So just very simply, familial hypercholesterolemia is characterized by scary high levels of serum cholesterol. And so it'll be higher than 240, it's usually double that or in the vicinity of double that. Your target though for LDL is 100. People with familial hypercholesterolemia, it'll be close to 200 in some cases, 190, 180, something scary. Diagnostic tools aren't standardized, but a good family history and blood cholesterol levels are good. There are good genetic tests that are available. Pharmacotherapeutic options are available and should be used, but lifestyle modifications are an absolute must, and some resources if you're interested. Now, to see how smart you guys are, let's come on, shrink. There you go. Okay, we're going to right. All right, 30-year-old, can you see that or want me to enlarge it? Better? Okay. 30-year-old woman presents in the emergency room with angina pectoris that began a few hours earlier during a soccer match. Physical examination reveals a lump above the Achilles tendon and yellowish patches above the eyelids. Don't give hints. Patient's body mass index is 23. What's 23? Above 25 is overweight. Below 25 is good. So body mass index is actually pretty good. So this chap has watched his weight. That's good. Follows a healthy diet, regular exercise routine. Good. So the smoking, the drinking, the what have you, not an issue here. Look at his labs. Is that good, bad, indifferent? What's that? That's not bad, that's scary. Okay, above 240 is high, that's 4 bloody 100. That's like scary high. Look at his LDL. That's what this level is. HDL actually for a guy, it's actually not bad. Triglycerides, not too shabby. Not too shabby. Above 200 is usually the range, but this isn't bad. But these two, Danger Will Robinson, essentially. You guys don't know what that means. Sorry, too young. Oh, you got it. Okay, you've seen Lost in Space. Okay. All right, so based on this dude's labs and what have you, oh, crumbs. Gotta shrink it. Okay. The mutation, what kind of mutation does he have? Is he homozygous LDL receptor? Is he homozygous ApoB? Is he heterozygous REAT? Is he heterozygous LDL? Or is he heterozygous ApoA? Let's take these one at a time. ApoA gene. What does the ApoA protein do? Does ApoA have anything to do with cholesterol? LDL cholesterol? No, no. So that's a red herring. That one we can ignore. LDL receptor, does that have something to do with high LDL? Yeah, it does. So that's a possibility. Heterozygous RET mutation. RET is an oncogene. Mutations tend to cause leukemia. Does that have anything to do with LDL cholesterol? Survey says no. So that one we can ignore. Homozygous ApoB mutation. Does ApoB have something to do with LDL cholesterol? Yeah, so that's a possibility too. Homozygous LDL receptor mutation. Is that a possibility? Okay, so we've got three possibilities, right? We've got B, we've got D, we've got E. Yes? Anybody? Is that unclear to anybody? Okay, now, is this dude heterozygous or is this dude homozygous? That's your next question. Homozygous, he probably had a total cholesterol of about 800. His LDL would probably be close to 500 or 600. It's half that. So he's probably a heterozygous. So I'm going to bet that it's this and not these, because we'd expect that to be a lot higher. See how I did that? Think if I gave this to you on a quiz, you can answer it? Yes? Emily doesn't look so sanguine. She's smiling, saying, don't bet you that. But Emily, did you understand why it's not a homozygote? Yeah, because the labs should be twice as high if it's that. So
already super high, so how do we know?
because if there's two, remember, incomplete dominance. So there's a gradient of phenotypes. So if he didn't have this mutation, it would be normal. He has it, it's here. If he's homozygous, he's here.
What if this normal is like
He's got a healthy lifestyle. Yeah, plus he's young. Young, pretty fit, exercises. Yeah, it's 400. Something's clearly wrong, but it's not 800. Make sense? Let's try this one. Let's say pretty high. And it turns out we were right. We were right. That was fun. Want to do another one? Okay, so let's go back and let's try this one. Nope. Come on, you. Okay. Yeah. Okay. Yeah, I want to start. I'm going to call the question up. I don't want to start. Okay. All right. 32-year-old woman presents to the clinic with deposits in the supraorbital area as seen on the photograph. How can you see it? Ooh, yellowish patch. Sounds a little like this, huh? Sounds a little like that. Let's keep reading. She states she developed these skin findings over the past year. She doesn't take any medications, has no diagnosed medical conditions, does not visit a primary care physician. Naughty. Family history is positive for her mother having passed away at the age of 50, secondary to a massive myocardial infarction. Ooh. Now the bells start to ring. Lipid panel reveals normal triglyceride levels, total cholesterol level of 420. Survey says, that's way too high, isn't it? In addition to dietary modification, which the following is the most appropriate treatment for her condition? Let's take a look at the list of drugs. And okay. Atorvastatin, erythromycin, ezetimibe, gemfibrozil, that's a fibric acid, or Lavazza, that is a modified fish oil. That's used for high serum triglycerides. Which drug do you think is the best for her? What's the first line for this condition? Statin. Which one of those is a statin? The one that ends in statin, atorvastatin. So your choice is atorvastatin.
Did you say that mine was the best tolerated or statin?
But that's not going to drop your cholesterol nearly. You can combine that with the statin, but let's see if she tolerates the statin first. Then you go from there. So let's try this. I'm thinking our confidence is pretty high. And Zava, boom, there we go. You guys are so smart. So if I gave you that on a quiz, think you could answer it? Yeah. Emily, come on. Where's your confidence, dear? Come on, get your confidence up there, darling. Okay. I wish all of you a very blessed Easter, and I hope you guys are well. You guys all get well, and if you go home, please drive safely. Some of you I'll see tonight, some of you I won't. Okay, that's all for today. Stephanie, I'm going to send you an email. I had a chat with someone at church, and she gave me some information I think will be relevant to some of the questions you've asked me. I will put it in an email, and you can ask me questions if you have any via the email. Okay?
Okay, thank you.
You're very welcome.
Have a good Easter.
Happy Easter.